Welcome to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Our focus is the novel coronavirus. I'm Josh Sharfstein, a faculty member at Johns Hopkins and also a former secretary of Maryland's Health Department. Our goal with this podcast is to bring evidence and experts to help you understand today's news about the novel coronavirus and what it means for tomorrow. If you have questions, you can email them to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, Dr. Sara Bennett speaks with Dr. Tafadzwa Chakare, the technical director for JHPIGO in Lesotho in Southern Africa. Dr. Chakare is a medical doctor, experienced in the management of HIV treatment and prevention programs. In their conversation, they address the current situation of COVID-19 in Lesotho, the challenges of managing the pandemic in highly mobile migrant populations, and the implications for critical HIV and tuberculosis programs. Let's listen.
Dr. Chakare, thank you so much for joining me today. As I think I've told you, I lived in Lesotho many, many years ago, so I'm very curious to find out how it's doing during this current outbreak. Maybe we could start out by you just telling me a little bit about the current situation in terms of COVID-19 in Lesotho.
Thanks, Sarah. So COVID-19 in Lesotho, at the moment, we do not have any confirmed cases, but Lesotho is a small country completely surrounded by South Africa. South Africa has the biggest epidemic so far in Africa, close to 5,000 or around 5,000 now. So with not so much testing happening and with a lot of movement between the two countries, there is always a possibility that we might have cases of our own that we have not yet found.
Mm-hmm. You were saying Lesotho is entirely surrounded by South Africa and their economies are very closely intertwined. I know that South Africa had a very strongly enforced shutdown that was enforced for several weeks. How has that affected Lesotho?
So when South Africa did their shutdown, that was towards the end of March, at that point, Lesotho was still open and Lesotho followed suit a few days later. Lesotho's hard lockdown started on 29 March. So in African communities and with labor migration patterns, people tend to migrate back to their villages and home origins when they are not at work. So Lesotho has thousands of people who are working in South Africa. So when South Africa announced their lockdown, they gave people a grace period of a couple of days. And during that time, people migrated back home, as you'd expect. So we had a lot of movement across our borders. And with that comes some concerns of possible movement of the virus from the commercial hubs in South Africa back to Lesotho. And by the time Lesotho did its own lockdown, which started from 29 March, we also observed a lot of movement from our own cities down to the villages. And that comes with some concerns of, as people move the virus, if they could also be moving.
Mm-hmm. And I understand South Africa is now talking about removing that lockdown, in part because of the very severe sort of economic and welfare consequences that it's had. What are the implications of that, do you think, for Lesotho?
So once South Africa has started opening up its economy, which I think today, 30 April, might be the last day of their hard lockdown. Mm-hmm. So once that happens, when people who are based here, some of them could start going back, but that will only happen when the borders actually open. And I'm not sure of the details of that, but we will see a reverse movement and people, like you said, the two economies are heavily intertwined. So with those movements, again, come concerns of transmission.
Mm-hmm. I know that Lesotho has very high rates of HIV, with about 1 in 4 people living with HIV, and along with that, high rates of tuberculosis, and that much of your own work is in that field of HIV and TB. How is COVID-19 in Lesotho, or the threat of it, I guess, at this point, because you haven't actually got confirmed cases yet. But how is the threat of COVID-19 affecting the delivery of HIV and TB services at the moment?
So, as I mentioned before, we are currently under lockdown for the past almost 5 weeks now. So, with that and our HIV and TB services and other chronic diseases that we manage, it comes at different levels. So, the first thing is people's ability to generate income is reduced. So, many people are in formal business. So once people do not have money to buy food, they also have reduced capability to move around and go to a hospital, for instance, to pick up their HIV medication or TB medication, whatever chronic disease. So those are some of the fears that we have, that people will not be able to access services. And even if they had that ability to move around, there is restricted movements that are enforced by the law. So people might not be comfortable leaving their home to go to the facility, even though this is allowed. But some people might feel that they might not feel safe. Public transport capacity has also been reduced to try and maintain social distancing. So the number of people that can be carried in a vehicle are reduced. So all of these might be barriers for some people to access services. So in response, the Ministry of Health, as well as JAPEGO, which is a partner for the Ministry of Health, we have been working to try and bring services to the people in communities, to try and meet them halfway and not have them come to facilities, as well as to try and decongest facilities. So once facilities are crowded, you have reduced capacity to implement some infection control measures. So the ministry has responded by providing a multi-month supply of ARVs and other chronic drugs, because we do not know where this epidemic is heading and would like our facilities to be relatively free. I work on a project that one of our projects provides pre-exposure prophylaxis. So we also recognize that during this time of COVID-19 and lockdowns, some people might be at elevated risk of HIV infection. And we work by going into communities and dispensing pre-exposure prophylaxis through mobile services, sometimes dispensing drugs from car windows, from our project vehicles, and sometimes working in people's homes when it is allowable. So we've tried to be as flexible as possible to make sure that services continue, but without asking people to necessarily come to facilities or congesting facilities.
Thank you very much, Dr. Chikare. And when you're talking about the people being on elevated risk of HIV during the lockdown, are you talking about issues around gender-based violence, which has also been a big concern in the US, for example?
Yes, so we have had anecdotal reports of spikes in gender-based violence. As you can imagine, when people are tied down with their partners in the same space for weeks on end, some of these partners might be abusive, so it increases exposure to that. But so that's the gender-based violence angle of increasing HIV risk and vulnerability. But beyond just the violence, we also mentioned that when lockdown started, we had people coming in from South Africa, people who work in South Africa. So once people come back into the country and go and link up with their partners and resume sexual activities, then there's always going to be a risk of new HIV infections. So this is a time that we thought it is important for HIV prevention, including pre-exposure prophylaxis, to be accessible.
Mm-hmm. You also talked about strategies that your project were using to try and get services to people within communities rather than making them come to facilities. But presumably that itself involves some risks in terms of health workers or community health workers going around people's homes. How have you been tackling that?
Yes, so the risk is real. So once we have asked our teams, so we have teams of workers and counselors. So when they go out into communities, we are cognizant of the fact that they might be exposed to the virus. So the first things that we first to implement is social distancing. So as much as possible, they try to remain a safe distance from their clients. But as you might imagine, that is not always possible. So when they cannot maintain a distance, they use face masks, and they have their supplies of medical face masks. We also encourage them to work from outside. So they work in open air environments. They would go and work under a tree if it's possible. But the services that they provide are also meant to be confidential. So they find a way of working to provide a convenient service to the client, but at the same time, keeping a level of privacy and confidentiality. And sometimes they find themselves going into people's homes. And when they do, we make sure that at least they are wearing a medical face mask to protect themselves, as well as to protect people in that household.
It sounds like everyone's having to be very creative to be able to find ways to deliver these essential services. And are your staff able to access adequate supplies of face masks and other personal protective equipment?
So that is an ongoing challenge that we are continuously trying to solve. So our program one of our projects does voluntary medical male circumcision. So we are lucky that we've always had a supply of surgical face masks. So these were things that were quickly medical circumcision. Then once the state of emergency came into action, the Ministry of Health declared that medical male circumcision should stop because it is a non-essential service. So we have redirected our surgical face masks to be used by our community health workers that are doing activities like pre-exposure prophylaxis and TB contact tracing. That said, again, we now struggle with stocks of those as well. So we are continuously trying to purchase them, but PPE is hard to find. And when you find it, sometimes the prices are inflated.
Dr. Chikare, thank you very much. One maybe final question before we close. It seems like the population in Lesotho have some particular vulnerabilities. We've talked about the high rates of HIV and TB, but I also know that there's relatively high rates of malnutrition amongst the population. What do we know about how these might interact with COVID-19?
We do not know enough, and all we can do at the moment is speculate. We know that HIV causes a weakness in your immune system. But we hope that successes that have been scored in terms of rollout of HIV treatment in the country, Lesotho is doing pretty well on that front. We hope that this has protected our population of people living with HIV enough to have outcomes that are comparable to HIV negative people. TB, on the other hand, again, we do not know enough, but we suspect that anyone with active TB disease, if they were exposed to COVID-19, might have poorer outcomes. I guess we will learn with time. And you've mentioned malnutrition. This is usually associated with poorer health outcomes when you're malnourished and you're hit with a new infection. Poverty, people's housing, the type of places where people live, could be a breeding ground for transmission of the viruses within families and within small neighborhoods. So these are the type of uncertainties that we face, and I guess we will know with time.
Thank you very much indeed, Dr. Chikare. It's been really fascinating to hear about how you're trying to manage the epidemic within the context of Lesotho. And as you were just saying, it sounds like there's still many uncertainties and many different ways that this could play out. So good luck to you and your team working to tackle healthcare in this difficult time. And maybe we can check in on another occasion. Thank you very much indeed.
Thank you, Sarah.
Thank you for listening to Public Health on Call, a new podcast from the Johns Hopkins Bloomberg School of Public Health. Please send questions to be covered in future podcasts to publichealthquestion@jhu.edu. This podcast is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Lamare Morales. Audio production by Niall Owen McCusker and Spencer Greer, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.